Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine, and I'm back with another interesting head and neck radiology case of the day. So as always, I'll start by saying that all of the educational content found as part of this presentation has been completely de-identified in order to protect patient privacy. So this is an older man who came in for imaging, totally unrelated to what's going on. I think he had a headache or something like that. That history is not that important because this was an incidental finding that was found on routine imaging of the brain. Again, older patient. So I've got 4 images for you to look at. The image on the left is an axial T2 weighted image with fat saturation. The second image from the left is a sagittal T1 weighted image. The third image over is an axial diffusion weighted image, and the fourth image over, the image on the right, is also an axial diffusion weighted image. These are trace diffusion sequences, and take a look at these images. Try to figure out what you think might be going on here. Okay, so 2 questions this time. What are the findings? And what's the most likely diagnosis based upon those findings, the patient's age, for this incidental finding? Okay, let's take a look at the imaging. First up, we have our axial T2 weighted fat saturated image. And what you can see is there's multiple bilateral intraparotid masses. They're not huge, but they are bilateral. You can see them denoted here by the yellow arrows. They're mildly T2 bright. They're not as bright as that mucus retention cyst that we see in the left maxillary sinus. They're not as bright as CSF, so we're not really thinking that these are sialoceles or some sort of a cyst, but these are masses. They're somewhat T2 bright. They're solid appearing. We don't see any necrosis, no focal areas that are really bright within them either. So that's what we see. Is there anything else? You see anything else going on in this image? I won't give the answer away just yet. Just look it over. What else do you see here? All right, let's move on to our sagittal T1 weighted image. Again, we see there's multiple intraparotid masses. These are T1 iso to slightly hypointense relative to the brain. I mean, it's tough to make a comparison. What's our reference standard? But they're certainly hypointense relative to the parotid tissue. And they're solid appearing. We don't see any areas of necrosis. These have very circumscribed margins. You could take a pencil and trace the margins of this. It doesn't look infiltrative. Let's look at my favorite pulse sequence, the diffusion weighted imaging. So we can see, again, on this axial diffusion weighted image through the level of the parotids, we see multiple bilateral intraparotid masses, and they're bright. I'm not showing the ADC map, but trust me to say they were dark, relatively dark on the ADC map. So these are high cellularity masses within the parotid. Diffusion weighted imaging, reduced diffusivity, we can use that as sort of a surrogate marker for cellularity of tumors. So in addition to those parotid masses, what else do you see? Look carefully. Anything else catch your eye? Again, this is an elderly patient. Look at the marrow signal intensity. The top 2 arrows are pointing at the mandible. The bottom 2 arrows are pointing at the occipital condyles. It's bright on the diffusion sequence. And this is an EPI or an echoplanar diffusion sequence. Those rely on fat saturation in order to generate the image, to prevent that, that chemical shift artifact that you sometimes see with silicon oil tamponade in the orbits, where it shifts that fat signal intensity off. So we have to give a nulling pulse as part of this in order to generate the images and cut down on artifact. So anything that's fatty should be suppressed, should be dark on this EPI diffusion sequence. And this marrow is not. This marrow is bright. That's not something we would expect to see in an elderly patient who should have fatty marrow. Let's take a look at this other axial diffusion weighted image. You can see that we have this abnormally bright calvarial marrow signal intensity. If we look at the calvarium here, it should be dark in an older patient. It should be fatty marrow. This is bright. We sort of get this Oreo cookie sign in which, as we work from outside to inside, we see dark subcutaneous fat. Here we see bright marrow just deep to that. And then just deep to that, we see that thin band of dark CSF. It looks like an Oreo cookie turned on its side. So we have abnormally bright calvario marrow signal intensity, should be dark in this older patient. We're suspicious here that there's something replacing the marrow. So as we take a second look, I should say, at our axial T2 weighted image, we can see that the marrow is bright. Look at the yellow arrows. The top yellow arrows pointing at the mandible. The bottom two yellow arrows are pointing at the occipital condyles. These should be dark with the fat-saturated technique. Normally, older patients have fatty marrow, and it should be dark on these fat-saturated sequences. So put it all together. Multiple bilateral, solid, mildly enlarged intraparotid masses with diffuse marrow signal abnormality. What do you think is going on here in this older gentleman? So this is a patient who had chronic lymphocytic leukemia or small lymphocytic lymphoma, whatever you want to call it, kind of synonymous. This is the most common chronic B-cell lymphoma, a non-Hodgkin lymphoma, in Western countries. The incidence increases with age, so we see it more commonly in older patients, and it has a relatively indolent course compared with other leukemias and lymphomas. In these patients, they have an accumulation of these leukemic cells within their marrow, hence the marrow replacing process that we see, but also within the lymphoid tissue. And as we know, the parotid glands are the only major salivary glands that contain lymph nodes. And also you can see them accumulating in non-lymphoid tissues as well. So again, I want to stress, this can involve the parotids. It's the only salivary gland that contains lymph nodes. Whenever you see multiple solid intraparotid masses bilaterally, one of the things you need to think about is lymphoma, non-Hodgkin lymphoma. So what's our differential for multiple intraparotid masses? Well, lymphoma. Metastases, you have somebody that has widely disseminated systemic metastases. They certainly can get multiple intraparotid nodal metastases. It's very uncommon, but we see it on occasion. Warthin tumors, they can be multiple and bilateral, or cystadenoma lymphomatosum, if you like to not name things after people. And then last would be oncocytomas. Oncocytomas are another tumor that not infrequently is bilateral and multiple as well, although it's a rare tumor. It's very rare. So one thing that I think is helpful to look for other clues that can help narrow down your differential diagnosis. Whenever you see multiple bilateral parotid masses, look for other clues. Those corner findings like cervical adenopathy. If we saw bulky cervical lymph nodes that were non-necrotic, we would be thinking about non-Hodgkin lymphoma. Look at the nasopharyngeal, palatine, and base of tongue lymphoid tissues. Those can also be enlarged in non-Hodgkin lymphoma. And again, this marrow replacement that this case nicely showed is a clue that you're dealing with something, a leukemic process, something that's replacing the marrow spaces. A little further reading, this is a paper that Rick Wiggins and I wrote a few years back, and it's just looking at the utility of diffusion-weighted imaging and diffusion tensor imaging for helping to differentiate benign and head and neck lesions. It's not a perfect paradigm, but it's something that can be a nice adjunct tool in addition to your other pulse sequences for trying to figure out whether or not something is benign or malignant. ADC values tend to be darker or lower in signal intensity in high cellularity tumors. High cellularity tumors are more commonly going to be malignant. Not always, again, not a perfect paradigm, but if you see a tumor that's ADC dark, be thinking this is a high cellularity tumor and therefore also more likely to be malignant. All right, let's wrap this up. Again, this is a patient with CLL or SLL, the chronic lymphocytic leukemia or the small lymphocytic lymphoma, however you want to word it. But they have multiple bilateral enlarged intraparotid masses. Those represent solid, non-necrotic, mildly enlarged lymph nodes. And they are high cellularity with the reduced diffusivity. They also have marrow signal abnormality with that high cellularity marrow replacement, something we do not expect to see in an older patient who should have fatty marrow. A couple pitfalls. Again, diffusion imaging, diffusion-weighted imaging is a great tool. It's not just for brains and strokes. Think outside of the brain. I think it can be very useful for looking for extracranial pathology, including those high cellularity tumors. You get really good signal to noise ratio in the sense that you null out a lot of the stuff. You don't see the fat, you null out a lot of the muscular tissue, so be on the lookout. If you see something that's bright on the trace diffusion and dark on the ADC map in the extracranial soft tissues, it's really incumbent upon you to figure out what it is. Try to locate it with the other sequences. If you can't figure it out, maybe get some more imaging and try to track it down, because it can be a very powerful tool for picking up on those extracranial tumors seen as part of routine brain imaging. And again, use those corner findings, things like enlarged palatine tonsils, nasopharyngeal lymphoid, base of tongue lymphoid that you can see, as well as, like this case showed, the marrow signal abnormality. They can help narrow down that differential diagnosis when you're looking at multiple bilateral parotid masses. Those would be features that would suggest you're dealing with lymphoma. As always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz. And you can also find our complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.